I'm starting there year 30. So it's a lot of years of doing this topic. So whatever mistakes that are here that you detect, they're my own. But it's a pleasure to see you all talk about a subject that I live and breathe every day for the last 30 years now at NYU. So cardiovascular disease, my topic tonight briefly is to just touch on some of the risk from cardiovascular disease. So it's every 34 seconds somebody dies of a heart event here in the United States. Annually there are about over 600,000 heart attacks. Over 600,000 people had their first heart attack, and 200,000 people had their second heart attack this year. So these are really common. And sadly, the trends are starting to turn in the wrong direction. I don't know if they told you there's a quiz at the end of this, so I need you to really pay attention. So this is a really common disease, and for our interests, the majority of heart disease is preventable. And that's why topics like this are so germane. So my goal is just briefly for tonight's short talk, talk a little bit about healthy living, take control of your risk, know your risk, know what you can do, and where you can get more information. And we'll close a little bit with how you might be able to help others, which is a subject that's really growing in cardiology today. So let's talk about the risk factors for heart disease. So I put at the top of this what we call non-modifiable, which means there's some things you're born with. You come from a family where everybody has heart disease, you have to be very concerned, because that's a non-modifiable. That's the genetics you're given from your parents. Age is a big risk factor for heart disease. As we age, there's an increase in incidence. But my purpose tonight is not really to focus on the genetics. That's a separate discussion. Although we do genetic screening in our office, I'm going to speak mostly tonight about what I call the modifiable risk factors for heart disease. That's about smoking, hypertension, high blood pressure, sugar, cholesterol, your weight, and physical activity. These are what the Heart Association has called life's essential 8. They want us eating a healthy diet. We'll touch on that in a minute. Exercise, touch on that in a minute. Keeping your blood sugar under control, that's a real problem that we're seeing every day. People don't even know they have diabetes. Their BMI, the BMI comes from old MetLife tables from the 40s that showed that if your weight and height were in a certain range, your risk for heart disease was dramatically lower than people who were at a higher BMI. Talk about cholesterol, pressure, smoking cessation, and the last one that I don't do very well in is optimal sleep. But the Heart Association thinks if you get a good night's sleep, your risk of a heart attack is actually lower. They estimate that less than 1% of the United States population actually is at ideal cardiovascular health. So these 8 modifiable risk factors that we'll go over quickly tonight, they think there's a lot of room for improvement. So let's start with hypertension. It's estimated that almost half of United States adults have hypertension, and if you live long enough, the estimates are about 90% will develop high blood pressure. You really have to have bracha to not develop hypertension in your lifetime. It's often asymptomatic, so for years it's been called the silent killer. And high blood pressure is not a disease of old people. So when I was a chief resident at Albert Einstein, we used to say, oh, well, you know, when you get older, your blood vessels get stiff and less compressible, and so if you check blood pressure in an older person, it'll be high, but it's not really hypertension. That turned out to be complete nonsense. If you treat hypertension, as I'll show you in a moment, in an older population, you cut stroke and heart attack and heart failure dramatically. Fewer than 25% of people who have hypertension actually have it controlled. And imagine, here you have a really common disease, and yet we're not doing that well. Again, genetics play a big role here. So we see thin people who are hypertensive come from families that have hypertension. The African American population has a lot of it. Being overweight increases your risk of it. And if you eat a high salt diet and you like to drink alcohol, you're at an increased risk. Same for a sedentary lifestyle. And of course, in the pregnancy population, this leads to issues like preeclampsia, eclampsia. Big deal because it can lead to big problems. So why bother? So a lot of people come to the office, they have hypertension, they want to try to do it naturally. They don't want to take pills. Well, the reason to bother is because it's a big risk factor for heart attack, heart failure, arrhythmias. We see what we call end organ damage. That is, when you have high blood pressure, you have problems with your eyes, you get headaches, you can be disoriented. It's a big risk factor for stroke, kidney disease, peripheral vascular disease. Many men come to the office, they have sexual dysfunction, they don't know why, and it's actually because their blood pressure is poorly controlled. So the Heart Association wants us to start with your food. When you deal with hypertension, I'm Ashkenaz, married to Sephardic, so I'm experienced with the wrong foods on both sides of this story. And soups are a common one. They're very high in salt. Chips are also very high in salt, and the high salt diet is a major contributor. In the Sephardic population, there's a lot of nuts, bizeh, dipped, chocolate. Now we've got salt and chocolate dipped. This is a recipe for trouble for blood pressure. Of course, a lot of the men and even some of the ladies like the hot dogs, and the beef kosher meat, of course, is heavily salted. But salt is a big contributor. You have to pay attention to your labels for your salt intake. And why bother? So I like to tell our trainees that these lines go in both directions. That is, we want to know, does the risk factor cause heart disease, and does treating the risk factor reduce heart disease? Well, in hypertension's case, it does. The higher your blood pressure, the higher your risk of stroke, heart attack, and heart failure. And if you lower the blood pressure, you cut dramatically the risk of stroke, heart attack, and heart failure. But we have, at all the city hospitals and at Maimonides, you have wards of people there with stroke, which to me is a failure, because that's, in the vast majority of cases, those are people who didn't have good blood pressure control. It's a pity. Okay, so these are some of this is a busy slide and it's too small for you to read from the back, but there's a lot of guidelines about what is really controlled blood pressure. What's optimal blood pressure? The Heart Association considers optimal blood pressure a systolic, the upper number, less than 120, the diastolic, less than 80. And they call it stage 1 when you're systolic, your upper number is 130 or higher. Well, when I was in training, you didn't get called hypertension unless you were 140 or higher. You can see why these numbers have progressively gone down, because stroke and heart attack and heart disease and kidney failure, etc., are big risk factors. So now you're called stage 2 hypertension if you're above 140 over 90. So the goals have progressively gotten tighter and tighter. And of course, we want to emphasize non-pharmacologic, not pills all the time. Weight loss, healthy diet, physical activity, stop the alcohol, etc. Okay, so that's hypertension. So take-home message on the hypertension: lower the better. We want you in the 120 range or less. That's really optimal. Cholesterol. We screen everyone. By the adult guidelines, you're supposed to be screened at age 20. The recommendation is to screen every couple of years. Most physicians in the Brooklyn area are screening annually. Again, lifestyle matters a lot for your cholesterol. We want weight loss, exercise, healthy diet, which I'll show you in a moment. And of course, we want to emphasize that when you ask your doctor for your numbers, that you know not only your total cholesterol, but what's the breakdown? What's my good, what's my bad, etc. So this is my best depiction of plaque. And a lot of people want to know if they have this. So I tell people this is often a silent disease. So for example, a woman goes for a mammogram because she wants to know if she has something in her breast, even before she develops the disease. People go for colonoscopy because they want to know, do I have something growing in me? Even though my bowel movements are fine, I feel well. Well, coronary disease is very similar. You have to check all these risk factors, and at the end, as I'll show you, there's ways for us to image the blood vessels and tell you if you have the disease, yes or no. Well, on top is a healthy artery. The roof of the artery is healthy, and there's nothing where the arrow is, there's nothing in between, nothing interrupting flow. In contrast, below, you see the buildup of plaque. Now that person may or may not have any symptoms, even though the disease is already growing inside their artery. You can see where the arrow, the white arrow is on the bottom. Flow is going through okay, but yet they have the disease. And if you continue, as the disease progresses, a small plaque shown on the bottom that wasn't bothering anyone. They could do their walk, they could walk to synagogue, they could do their errands, never had chest pain. On the fateful day that the plaque busts, like a pimple that pops inside the artery, the body can step in and seal it with a clot that's shown in the bottom panel, and that's how heart attacks happen. And that explains why many people never had any symptoms, and the first time they show up with being told they have artery disease, they're in the emergency room with a heart attack. Well, that's why we're so interested in cholesterol, because cholesterol is one of the main components of plaque. When the artery wall gets sick from smoking, from pressure, from sugar, cholesterol is allowed easy entry, and the disease really can accelerate. So our bodies make cholesterol. Everyone has it. You're not alone if you have been told that you have cholesterol. We all do. But we want to know the components. What's your good? What's your bad? And there's a lot of additional testing that can be done today. We can really see very quickly the genetics. There's a particular type of bad cholesterol called lipoprotein a that's very associated with premature plaque. It's an easy blood test. Many people haven't had it done. Easy to answer, yes or no. Do you carry these particles in the blood? Well, I mentioned earlier that the lines have to go in both directions. We want to know, does the risk factor predict disease? Does lowering the risk factor reduce disease? For hypertension, we know the higher your blood pressure, the higher your risk. The better we do with blood pressure, the lower your risk. Same is true for cholesterol, especially for the bad cholesterol, known as LDL, which is Rashi Tevot, low-density lipoprotein. That is, we know the higher your LDL, the higher your risk of heart disease. And every trial, shown in the small print here, that's been done to lower bad cholesterol is associated with less disease. And yet, if you stop someone and you ask them about their business, they'll answer you very detailed information about their business. But if you ask them, do you know your LDL cholesterol or what your blood pressure is, many times they don't know the answer. Well, lipoprotein A has gotten a lot of attention. I run the clinical side of the cholesterol research section. We're doing several trials with new drugs that are coming. I hope with a little blessing they'll be on the market in early 2025. But now one of the main genetic components of cholesterol, the elevated lipoprotein A, that type of bad cholesterol that contributes to disease, will soon be very treatable. So there's a lot of good stuff coming. In the interest of time, I'm going to skip this, but the national guidelines have put a lot of emphasis on your age and knowing, of course, whether you have disease. There's lots of different treatment. You've all heard about statins that reduce cholesterol production. We have drugs that interfere with cholesterol absorption. We have new agents that help deliver clear cholesterol that are very powerful. There's very little reason today not to bring someone's bad cholesterol under control. Okay, so let me skip ahead. So let's continue on our prevention thing today. So I want to touch on a little bit today about diet and physical activity, and a little bit at the end about the testing. So I grew up with this large trial, the Mediterranean diet. You've probably heard this. It goes by different names in the medicine literature, but basically it's the story of fruits and vegetables, and they want that to make up the bulk of your meal. I hear a lot from the community, a lot about meat, rice. It's not heavy emphasis on, and nor is my Ashkenaz background heavy emphasis on fruits and vegetables. We grew up at barbecues where you proudly showed your whole plate was full of meat. That's not where the emphasis should be. We don't really take any food away from people. We couldn't if we wanted, but we want to emphasize the healthy parts of it. So the Heart Association's got what they call 3 diet rules, 3 rules of thumb. One is, do you even know what you're eating? You know, if you buy something in a bar, a bag, a box, a can, you have to be a chemist to even figure out what's in it. So the Heart Association wants you to, what they call, eat food that your grandparents would recognize that that's food, that they know what it is. They could tell you what it is. They talk about a rainbow in your tummy, meaning it should be full of those colored vegetables and fruits. Simple. Keep the food simple. And lastly, they want to minimize the animal fat. And this is, again, most of the Jewish communities are falling short here with eating meat, heavy meat intake. We want to emphasize, we don't take meat away, but we want to emphasize salads, fish, vegetables, things like that. We're not doing that well on that front. So this has been shown sometimes in a blue and red, like a Democrat-Republican map, but the incidence of obesity is really rising. BMIs are high. If you look at people's height and weights, overweight here is called a body mass index above 25. And you're obese when your body mass index is above 30. And you can see the red, how many states are quickly reaching where large percentages of New Yorkers are overweight. We're already well over 20% of New York is considered obese. So weight's a real problem. And they think that we're not doing enough of this Mediterranean diet, not enough of the whole grains, about fruits and vegetables. If you're having meat, lean meat, but we prefer the fish. The nuts look okay, but not the dipped, not the salted, just raw, just the plain raw nuts. Olive oil, if you have to cook in something, that looks okay. And we want that the dairy products be low fat, fat-free, and less of the meat and the processed foods. Most of the people, if you hear their diet, there's a lot of carbohydrate, a lot of meat, a lot of rice. So not ideal. It doesn't take much weight loss to lower your risk. We get asked this a lot. What's my target weight? So I already talked about the BMI, but the Heart Association has data that shows that if you lower your weight by even 5%, your heart risk starts to decline. Weight loss delays diabetes, and if you add a little exercise to that, you can really achieve quite a bit. Well, is there data for this? Is there data that changing your diet actually reduces risk? And the answer is there is. So this is a very large trial. It's called Primary Prevention of Cardiovascular Disease with the Mediterranean Diet. It was a headline article in the New England Journal of Medicine. And although I know you're sitting at a distance, but what you can see is that on a Western diet, the heart disease risk was substantially higher than those who ate fish, salad, vegetables, a more Mediterranean diet. How about activity? What should I be doing in terms of physical exercise? So again, there the Heart Association has some basic advice. They want it to be safe. I know that sounds odd, but we see people doing things that I'm not so sure they're really up to. Ideally, it should be easily accessible to them. It should be something you can do in a regular way. When I was a chief resident, we used to talk about, the books would talk about a guy going out to shovel snow, hasn't done anything all winter, and he's out there shoveling snow for 4 hours and he has a heart attack. We want it to be that there's physical activity on a regular basis in your life. And it's supposed to be fun. So it's not a chore. They call it, make it functional. But the idea is to make it enjoyable so it's not a burden. How much exercise? Well, the Heart Association is trying to get people even to walk. Brisk walking looks really good. People think they have to run, sweat. If I'm not in a gym, I'm not really exercising. That's great if you want to go to the gym, but even without a gym membership, if you just get out for walks regularly, it looks quite good. You can try to get to people to do about 200 minutes a week of exercise, 30, 35 minutes a day, ideal. Anything more, kol hakavod, all the more. And what you see from the trials is that the biggest bang comes from doing nothing to doing something. So many people say, well, I have hip problems, knee problems, everything hurts me, my back hurts me, I don't really have time to exercise. Turns out if you just do a little, your heart risk, you can see from this large trial in the Heart Association's journal, it's been replicated more than once. Even just starting, just saying, okay, I'll just do 5-10 minutes. Just doing a little bit of exercise, cut the heart risk substantially. So the biggest bang, biggest reduction in the slope of the events is happening just from starting to exercise. So think about your week, your day. Did you build it into your day where physical activity is part of your routine? Many people tell me, I do it in the summer when I go to deal, but during the winter it's too cold, I don't really. No, there has to be some time for that during the day as well. Keep in mind that exercise alone doesn't really lead to weight loss. Weight loss, it's really about your food. It'll help to exercise, but I've not met anybody who can, very few. Michael Phelps, the swimmer, he could out-exercise. He could eat 8,000 calories a day. But most people, most humans won't be able to do that. We exercise for heart health, but not for weight loss. Okay, we mentioned even small amounts reduce risk. Let me move on to diabetes as a risk factor. This is a gigantic one because there's so much obesity, so much overweight, there's a high incidence of diabetes. So you may be aware that the FDA has mandated that any new drug for the last many, many years, any new drug that comes out to lower somebody's blood sugar has to be proven to be heart safe. This is the only class of medicines that are asked to do this. And the reason is because diabetics mostly die of heart disease. They don't die of having a high per se of their sugar, they die of heart complications from having a high sugar. Well, the Heart Association and the FDA have all been doing these large outcome trials of medicines that lower blood sugar, and many surprises have come from those trials. You've probably seen some of these. There are commercials now for a drug that causes the sugar to come out in the urine. First one to come out was a drug called Jardiance. It belongs to a class called SGLT2. You could see, unexpectedly, the company was just trying to prove that it lowered blood sugar. Unexpectedly, it cut heart failure by 40%. So now you see these commercials on television where an actor comes up to somebody and says, "You aware that this drug that improves diabetes actually cuts heart failure by 40%?" And the actor amazingly says, "No, I didn't know." "Well, then why are you in this commercial if you didn't know?" And anyway, there are drugs that not only lower your blood sugar, they cut heart events. Jardiance is one. The whole class, it's called SGLT2s, all lowered heart disease. You are probably meeting or seeing, or maybe you've tried it yourself, the injectable drugs for weight loss. They are raging in the country. After Kim Kardashian used one, the use of the weight loss drugs really took off. And those are drugs like Ozempic, Mounjaro. These belong to a class called GLP-1s. They have great heart data. There was just recently a trial called Select with Wegovy, a drug that leads to weight loss, improves blood sugar. 17,000 patients cut heart attack and stroke. So diabetic drugs are no longer just about lowering blood sugar, they're about reducing heart disease. Well, nowadays, you can on your phone, if you want to know your risk and you know your numbers, you could put it into what the Heart Association, American College of Cardiology, have used as a so-called risk calculator. You take your age, your blood pressure, your cholesterol, whether or not you have diabetes, whether or not you smoke. You could plug in your numbers and learn quickly what's your risk. So I did that here on an average patient who's 50 years old and comes to the office with a blood pressure of 160, and he has a total cholesterol of 220. He's not on any medicines for his cholesterol, has a bad cholesterol of 150. He's got a 10-year risk of 5.8%. You say, well, that doesn't seem so high, but actually his lifetime risk of heart disease is 50%. So you can see that just in quotations, just modifying blood pressure, sugar, cholesterol, lifestyle can really sharply reduce that risk. There are other what we call risk enhancers. So many people come to the office and they want to know, tell me exactly, do I have any plaque in my arteries? There's a lot of ways for us to answer that. We have actual pictures of that. The most popular one, which I'll show you in a moment, is called calcium score. In New York City, this test goes for about $150. Used to be much higher cost, used to be high in radiation. It's not anymore. In a 10-minute scan, a radiologist can tell you if you have plaque in your arteries. That means we're not guessing. We're not going, oh, here she looks like she might have heart disease. No, we're not in that era. You want to know, yes or no, do I have plaque in my arteries? We have a 10-minute scan that can tell you if you have plaque in your arteries. A normal calcium score, 0. You're called mild disease if you're 1 to 99, moderate if you're 100 to 300, greater than 300 or 400, you've got a lot of plaque. This is what it looks like. So this is a 10-minute scan, no real heavy radiation. And you see these bright white spots? That's the outline of the heart's arteries. That's calcium. Now calcium is something you see in bones. When I was in training, we used to call it hardening of the arteries. Maybe you've heard that expression. That was coined by radiologists because they were taking pictures of somebody's chest, looking at their lungs and going, wait a minute, why am I seeing their heart's arteries there? They don't belong in that picture. They belong in that picture because the arteries are full of plaque. That's somebody who has a very high calcium score. That's trouble. That means their goals for cholesterol are that much tighter. Their goals for pressure are tighter. Their sugar goal, the whole thing needs to be treated. Well, here's the outcome data. This is what it looks like if you have an abnormal calcium score. If you have shown on the top bar, if you have a calcium score of 0, your risk of having a heart event is really, really low. And the more plaque you have in your heart's arteries, you could see outcomes are getting worse and worse and worse. So those are the groups that we're really targeting. And we don't have to guess. A 10-minute scan and a visit to a a cardiologist's office, we can answer that question, do you have plaque? Now you're also aware, and I didn't show you this in slide, but you're also aware we have the pictures here that can show if you have plaque in the neck artery. Between artery pictures of the heart and artery pictures of the neck, there's really no reason why anybody would be guessing whether somebody has artery disease, yes or no. A couple of just last closing comments, and then I'll be happy to take some questions. Alcohol. So I grew up in an era where we were taught that if you drink, you're going to be protected. Your good cholesterol will go up, and you'll be protected against heart disease. Unfortunately, while good cholesterol goes up, this teaching that we're reducing heart risk from alcohol use is sadly not really there. Tobacco. Thankfully, I'm not seeing so much of that in the community. I think that the message has kind of been loud and clear. I think most people know that if they smoke, they're at risk of heart disease. You're damaging the artery wall. Coronary calcium goes way up. You're developing plaque. You're allowing cholesterol easy entry. So this is really, hopefully, there are drugs and things that can help you stop. I've often told my wife the story of a middle-aged Syrian man when I first started practice at NYU about 30 years ago, who came in with a heart attack. Those days, there was a waiting area, and the son was in the waiting area, and he was smoking. And he says to me, "Why did my father have a heart attack?" And I said, "Because he smokes." And I said, "And if you were wise, you would stop smoking." And he says to me, true story, "Doc, when it happens to me, I'll stop smoking." Well, about 3 months later, he was on the table with a heart attack. And thank God, they both stopped, and they're both doing fine. But, hello, we have to, smell the coffee. I mean, if you know something's a risk, why do you keep doing it? I mean, smoking cessation, it should go without saying. Okay, so just one or two comments about heart disease in women. So the Heart Association thinks we're not doing enough testing in ladies. And they give one statistic that really jumps out. And that is, it's the #1 killer in women. This is what women die of. So every woman goes for mammogram screening. Understandable. I don't want to get in the way of that in any way. They go for mammogram screening. Well, you may not be aware, but the incidence of heart disease is 9-fold more common than breast cancer. But yet everybody's going for breast screening and nobody's getting their heart screened. So they have wear pink day, wear red day. The Heart Association has tried to get this into the mindset of people that heart disease is in women as well. They get it about 10 years later than men do. So we start seeing big spikes in incidence in women about the age 60 and higher, whereas men, it's about 50 and above. And we have to test women for symptoms that aren't exactly the same as the symptoms in men. Sometimes they present with just neck, jaw discomfort, shortness of breath, cold sweats, some nausea, some vomiting. They just don't feel right, and it's heart disease, even though they want to explain it away by other things. Message: women should be tested as well. And again, it's 10-minute non-invasive test, simple risk factors, the essential 8 that we spoke about earlier today. So I want to just close with some of the testing. So I mentioned for people who want to know, we have screening tests, 10 minutes, you can take a picture of your arteries and answer the question. Of course, you all grew up with the testing that I grew up with, and that's the more detailed functional testing. Stress testing, where you put someone on a treadmill. There's nuclear imaging, there's stress echo imaging. There's a lot that can be found today. No reason, most insurance covers these tests. And I'm just a faculty guy. I'm not somebody who makes money from doing tests to people. But there's no reason why you can't get imaging. It's easy to answer. This is not a hard disease to diagnose. This is an example of what nuclear stress test is. It takes a little longer for people even who can't exercise. We can get pictures and tell whether they have artery disease. I want to just show, you've all grown up in the era of an angiogram or catheterization, or as Israelis call it, sintur. Well, this is somebody who things had progressed to a marked degree, and it's a little faint. Maybe you'll see it better on the video, but this is somebody with in 2 minutes, with a very minimum amount of contrast, 10 cc's of contrast, we can show somebody's coronary arteries. Even people with advanced disease can be helped. This is a 70-year-old who has a severe blockage shown here in the coronary artery. You can see there's an interruption of contrast going through the artery. This is severe disease. This is what we're hoping to avoid. This is what we're hoping to prevent with simple control of risk factors. Last point, and I'll close with this, about helping others. So the Heart Association is trying to get people to do advanced training for CPR. I was in a synagogue in Lawrence Avenue many years ago when somebody collapsed, and luckily the synagogue had a defibrillator. That patient who survived ended up buying defibrillators for the whole Jersey Shore. But what's needed is knowing how to do CPR. So I think Bikor Cholim has done it in the past. I'm not sure, Rebecca, you may know better. But I know in the past I remember seeing flyers for this. We have to do this as physicians every year. Hospital makes us, update our CPR, basic life support. You do it. Yeah.
Link does it every summer.
Great.
During the 3 weeks.
Great. Okay. So
For free.
no reason why not to do this. You can learn. You may be able to save a life, and knowing how to do CPR is really potential lifesaver. Today we have automatic defibrillators, and many of the synagogues have them, and you just apply them to the chest, and it talks you through exactly what to do. So thank God there's ways to help. I want to close with just knowing your numbers. I tell people that they're very good at knowing their business, knowing their stocks, what their stock did from today to yesterday. They can tell you exactly what NVIDIA did, But if you ask them, what's your blood pressure? What was your blood sugar? Do you know your numbers? Those numbers they don't know. But those are predictive of their risk of having a heart attack. So we want your blood pressure less than 120/80 if we could wish it. We want low triglycerides. We want an LDL, bad cholesterol, as low as possible. I have a colleague who likes to say it can never be too rich or have too low a bad cholesterol. We want a weight that's really trim. So much so that hopefully your family members are saying, hey, you look great. You look really slim. We want a sugar that's controlled. A normal blood sugar is an A1C that's less than 5.7. And as I mentioned earlier, we have meds that will help get you there. If you can't get there with lifestyle, there's plenty of medicines that can help do it. And lastly, the take-home point about the cholesterol. We have a lot of outcome data showing that when you obliterate or really control your bad cholesterol, you really sharply reduce your risk for heart disease. So thanks for coming out on a cold night, and I'm sorry if I threw a lot at you, but hopefully you know a lot of this and this is all reviewed. So, and I'm happy to answer any questions. Thanks for having me. Rebecca, thanks for the invite. Yes, young man.
So logically, exercise doesn't make sense that it's good for the heart because it's working the heart tough. It's like a car, like if you go 120 miles an hour, it's going to ruin the engine. So how is exercise?
Yeah, so the blood vessel wall, the permeability of the blood vessel wall turns out to be a lot less leaky when people exercise regularly. Plaques break much less in people who exercise regularly. And as I said, as I showed you in the slides earlier, it doesn't take much exercise to see the benefit. So when I was a cardiology fellow at NYU, the teaching was that you have to sweat, you have to turn red, and then all these trials started coming out. You've probably seen them. There are apps on the phone. My daughter hooked me up with it that will count how many steps you do. Well, you've all seen this data. You do 10,000 steps a day, you cut heart disease risk dramatically. But yet they're not running, they're just walking. Well, there's a trial, I didn't show this in the interest of time, but there's a trial from Latin America where they don't, one of the countries that they don't have much, they're not able to drive much. The gas is very expensive, so they walk everywhere. Their average steps are 15 to 17,000 steps a day. They did imaging of their arteries. They look 30 years younger than age-matched controls here in the United States. So the power of the physical activity is dramatic. And yet, you commonly, I spend my whole day with patients on these topics. I'll commonly ask somebody, say, yeah, I know, doc, when I'm in Deal, the boardwalk, I go, I walk. But during the winter, you want me to exercise? I don't have time for that. No. Can you make time for that? Your arteries have stuff in them. Can you please make time for that? I mean, begging people to just please to start, even just a little bit of activity. Doesn't have to be, make it functional, as the Heart Association calls it. Make it enjoyable. Go out with your spouse, whatever, but just get out. Go for the walk. I tell people if you're the Wall Street crowd, I've told for many years, 5 minutes on the hour. Just walk around the office. If you did that 5 minutes, lift your desk for 5 minutes, you just added an 8-hour day. You added 40 minutes of physical activity. You can do this. It's, in Hebrew they say betach bulot, with tricks, you beat the Yetzer Hara, but you could do it. But it's a matter of just, has to be built into your day. Yes, sir.
One of the questions is, during COVID, everybody, I don't know if everybody, but I did, we bought these pulse oximeters
Right.
to see about the oxygen level.
Right.
But it also tells you the pulse rate
Right.
at the same time. And you
Right, I
didn't
didn't
mention
cover
anything
that.
about
I didn't cover
pulse
that.
rate, but
Great, so let me do that. So good question. So there's guidelines that talk about what we call the cardiac training effect. So people who really want to get fit are trying to get what they would call an aerobic workout. So the numbers go like this. So if we do somebody a stress test numbers, it's 220 minus your age. So take your age, 220 minus that is your 100% of your target heart rate. To get what's considered a good aerobic workout, it's 70% of that number, so 220 minus your age, 70% of that number, and keep it there for 20 minutes. It's considered you got a very good aerobic workout. And again, that's much less activity than we used to think. You take people on a Peloton, on an elliptical, there's so many ways today to get that activity. Or go out for a walk, take a few hills, you'll get there. But even people who didn't get to that exact number, again, the heart benefit's very clear from the physical activity. Others? Yes, please.
That's two questions.
Sure.
First question is, I hope we get VIP to get an appointment with you. And number two is, you talk so much
Be careful,
about,
Liam gets VIP always.
you talk so much about medication.
Yeah.
There's medication for this, there's medication
Yeah,
for that.
only for people, of course, who
Yeah,
lifestyle
me.
alone doesn't fit.
But
Yeah.
aren't we putting, not me, but someone who's taking all these medicines, putting yourself at risk for other things, because there's always a side effect that comes along with it?
Great question. So, and that's a common refrain we hear from people. So, I always give people the analogy, what I call the tumor analogy. You take somebody who says, and I hear this virtually every day from patients. I don't really like meds, doc. Okay. So they go for a colon screen and they have a tumor in their bowel. And the doctor says, you're going to need surgery, you're going to need chemo, radiation. Will they do it? Yes, 100% of them. But there's a growth in the bowel, they'll do it. But when there's a growth in the artery, somehow there's an expectation that if I just eat broccoli and lettuce and, what a patient of mine calls rabbit food, somehow that stuff that's growing in there will just go away. And we have to sort of wake up to the idea that there are a lot of genetics behind heart disease. We see a lot of families who have high incidence in their family of heart disease through no fault of their own. We get people who come in, they're eating terrific, they have very good physical activity, they're eating a great diet, and you take pictures and they happen to have a lot of disease. We don't want to rely on just lifestyle. We have, thankfully, a lot of medicine. Now I want to tell you that the number of medicines, although I mentioned a few, the number of medicines proven to reduce heart disease are few. But those that do it become the ones you hear about. So cholesterol lowering, it's not by accident that it became, offered to millions and millions of people. It earned its place there because lots of trials showed higher the cholesterol, higher the risk, the lower the bad cholesterol, the lower the risk. And even people with advanced disease who got treated with cholesterol medicine had less events. Shame on us if we don't offer those types of life-saving medicines to patients. I gave you the modern day examples in diabetes of medicines that led to weight loss, dramatically improved blood sugar, and in a large trial in non-diabetics, cut heart attack and stroke. I mean, again, shame on us if somebody's overweight and can't control it with diet and exercise. Shame on us if we're not offering them at least these kinds of medications. Now, I didn't mention aspirin, but of course, blood clots are a big part of this story. And for people who have, high risk anatomy, bad disease, secondary prevention, somebody's had a heart attack, they're almost all on blood thinners. The role of the blood thinner in somebody who hasn't had a heart attack is very individualized. That is, there have been trials that in people who are properly treated for cholesterol and sugar and pressure and things, it's kind of a mixed bag of benefit for aspirin. Not everyone has to take aspirin. That's an individual case discussion between patient and physician. But yeah, I hear you. I don't work or speak for industry. I don't lecture for industry. I'm not here on industry's behalf, but I consider myself a patient advocate, and I want to make sure that patients who have the disease are getting the best of therapies of today. Other questions? Yes.
If you have like a very low HDL,
Right.
88 for example, and LDL is 157.
Right. You mean a very high HDL. So HDL of 88 for a woman would be a quite high HDL.
No, well, because HDL is the
HDL is the good cholesterol.
The good cholesterol
Yeah.
is 88.
Yeah.
Sorry, and LDL is 157.
Right.
So I don't know. That's what I have, and my doctor told me that I don't need medicine because
Great.
there's a balance. I don't know why. He
Great.
said
Great.
the studies show that you don't need to take medicine.
Great. So we don't want to make that conclusion solely on the blood test. That's where I gave as an example where
The
with a
calcium test?
with a
Okay.
simple imaging,
Okay.
we could answer which are you. Some people have a high good cholesterol because the body's just not removing it efficiently. That's a disease called CTP deficiency. They have a high good cholesterol. A woman came to the office with a good cholesterol 130, but full of plaque. She has a disorder where her body doesn't remove good cholesterol
So if
efficiently.
you have a 0 calcium, is that?
Okay, so then that tells you that good cholesterol is functional, and your need for treatment would be,
Lower.
much
And
lower.
what if you have a family history that's very not good?
Right.
Then what?
So I attended in the Bellevue, our city hospital's cardiology clinic for over 10 years, helped supervise.
Right.
I tell people if you don't have access, again, cost isn't really, it's a pretty low cost item. People are spending more on, ladies are spending more on a dress and shoes than they would on whether or not they have the disease. There's very little justification to not be imaged today,
But what do you
to be
consider
guessing.
imaging?
Again, I mentioned you have the
The
calcium
calcium?
score, you have an ultrasound that can take pictures of the neck artery. We can easily answer if somebody has plaque, yes or
Right.
no. If they don't have any plaque,
Right,
I'm not sold that everybody needs to be on medicine for that.
but even if you have.
But if you
history in
do,
the family,
if you
there's-
do, you basically would have to discount that high good cholesterol, say it's not really working because it's not cleaning my artery walls of plaque,
Right.
and you have to again treat that bad cholesterol has to be below 70 for somebody who has plaque. So in that particular case, we would treat, but only if there's disease. And we don't want to be guessing. We don't want to just look at the blood test and say, oh, well, nothing to worry about here. It's pardon the expression,
So
a
you
little
say-
outdated. I would ideally get imaging when you're on the fence. When either the doctor's not sure or the patient's not sure, great time for adding some pictures.
And the defense is the calcium test,
There's an ultrasound of the carotid arteries.
Okay.
It's easy to do, no
Yeah.
needles, no radiation, no risk, and can easily answer if you have plaque in the neck artery. It's been joked that if you look at the heart's arteries and the neck arteries, you've looked at like if you were screening a house, you just did a walkthrough of the first floor and the master bedroom, and you know a lot about that house. And again, why be in the guess
Right.
situation? Yes, Clint.
So what do you do? Just go to the doctor and say, I want to have these tests?
Well, a lot of people do that. A lot of people
They'll do
come.
it.
A lot
Just
of
go in and just
yeah.
say,
A lot of people come
"I want
asking
it."
for imaging. Now, look, not everybody needs
Saying
imaging.
like it's,
Not everybody needs imaging. Let me be clear.
But
If
that
you
was-
know you have a risk factor, for example, you're diabetic, you're a smoker. Not everybody has to be
but what
imaged.
if you-
Those have to be
you're just
treated.
nervous and you want to get it
Yeah,
done?
so
Like,
that's
you
what
know,
a visit's for. That's where
I'm saying,
physicians
like, then
will commonly do testing like that.
Okayed,
Yeah.
insurance. And
Again,
all
it's not
that.
high cost. A calcium score without insurance, $150, and that's in the city. In Brooklyn, maybe even less. Because we're not talking about high cost tests.
It's good to know.
Yes.
It's good to know.
Can
Sure,
you
sure.
reverse the progression of the
So we don't have any liquid Drano. That's a great question. I have colleagues working on that, and that's the holy grail. It was hoped that if you lowered bad cholesterol to a really low number, or raised good cholesterol dramatically, that you would melt away plaque. The studies don't show that. The studies show you could arrest progression of disease. Well, what's there, it's not like doing tshuva, if you commit sins and you repent, you can turn it into into mitzvah. We don't have the ability in cardiology to do that. So if you've developed,
You're just slowing down.
you can arrest its progression, but more importantly, when you lower, in the example I showed you, when you lower someone's bad cholesterol who has plaque, the plaques don't break as much. It's when they break and pop and the body steps in and seals it with a clot, that's how the heart events are happening. So even though the plaque is there, it's biologically, it's becoming like a birthmark. It's there, but it's not bothering anyone. It's not causing chest pain. It's not causing a heart attack. Frankly, who cares that it's there? We don't have to melt it away. All we have to do is render it biologically inactive. And if we do that, we've done our job.
And the stents, how do you put the
So
stents?
stents is really, this is plumbing. It's plumbing. If you have, I married a girl from Brooklyn, and I give people the analogy of the Belt Parkway, okay? The entire time we've been married, we're married since 1990, the Belt Parkway has been under construction. There's been a truck on the Belt Parkway that's doing stuff to the highway, but it's still the Belt Parkway. So so you would ask, I think very wisely ask, so if I open someone's blockage, mechanically, are they no longer now in need of medication? And the answer is no. They need they benefit even more because they have those non-severe plaques that are just as at high risk for breaking and causing clots and causing events. So that's the group, that's what we call secondary prevention. They already have the disease, we're trying to prevent another one. And there, the data is even larger. The regression and the reduction in events is even larger than in primary prevention. Yes? Yes, sorry.
What about triglycerides?
Yeah. So the very high triglycerides are associated with pancreatitis. That's its most famous. Triglycerides above 1,000 are associated with inflammation of the pancreas, and that, God forbid, can be fatal. So we do lower triglycerides, but the triglycerides and good cholesterol are very linked to what are called the metabolic syndrome. One of my colleagues likes to say, it was initially called the dysmetabolic syndrome. He likes to say that's like having the name Schwartzbard, like somebody should have shortened that. Okay, bad humor, I specialize in that. But you can improve a lot your triglycerides and good cholesterol with lifestyle change, and not necessarily needing drugs. Drugs for those with really high triglyceride, but not for all. I'm sorry.
Last year, I went to NYU, I did the test.
Okay.
There were 5570 closing artery.
Okay.
I rushed to the hospital, happened, I did it in Mount Sinai. They went inside with the procedure, they find out only 30% is closed.
Okay.
So they went out.
Okay.
So 2 weeks ago, I was in Aruba. I'm walking for like 5 minutes to the shoot.
Right.
Even my chest every morning killed. So I rushed to the hospital to NYU. I did the procedure, and the same artery probably was closed 95%.
Right.
So I
So
did it with Dr. Roy.
okay.
You know Dr. Roy, right?
Yeah, sure.
What happened?
So good. So that's without going back on the slides. I showed you an example of how a plaque that if you remember that arrows that I showed you an example of a plaque that isn't bothering anybody. 20, 30%, person like that does their activities, feels nothing. On any fateful day, that plaque can break. If that plaque breaks and the body starts to step in and seal it with a clot, within an hour, you could take someone who has a plaque of 30% and suddenly it's a plaque of 90%.
That explains so much.
And all of a sudden, a plaque that wasn't bothering anyone, you ask, well, yesterday I walked to shul, I didn't have any symptoms.
So how do you prevent?
That's where
The medicine?
that's those life's essential 8 that we're talking about. That's what, we're not melting away the plaque that's there.
Right.
We want to, as I mentioned to your partner, we want to render that plaque biologically inert, make it quiet
How?
by controlling cholesterol, controlling pressure, controlling sugar, etc.
Stuff.
All those really, I don't know your numbers, but all those risk factors, the better controlled they are, the less the event rate. So I was involved in a large trial with an injectable drug for cholesterol. They brought bad cholesterol down to 19. it cut heart attack 20% in 2 years. So there's a lot that can be offered, but the question is, do you know your numbers? So you knew them. You were
But I'm
quoting
still
them to
not-
me.
I'm still
You know
not-
them.
But I'm still.
But my point is that many don't, and especially when, you know, for you in the back who that asked that question, whenever there is plaque and there's been events, that's somebody who needs really well controlled numbers, really controlled sugar, really controlled pressure, really controlled cholesterol. You need all the risk factors, all the ducks lined up. No different, I tell people, that are terrific at business, no different than the same kind of attention you would pay to your business. If you had a sales line that wasn't working, you would cut it. If you were losing money on it, you would say, no, I'm not doing this anymore. Well, we have risk factors that need to be cut, and we can't just allow them to keep going. We have to, yeah, so that's the risk. That's, there you go. There you go.
But generic.
And that's the vulnerable plaque. And your story is the story of a vulnerable plaque. A plaque that may not have been bothering you, and all of a sudden, it popped. And when it popped, and you did the smart thing, you acted on it. You went and treated it. But I don't want you to view the stent of a blocked artery as a cure of the disease. It's really, the cure is getting all the numbers where they really need to be. That's preventive cardiology.
He doesn't look heavy, does he?
No, he's,
That's my whole point. That was my point to his wife's question, which is this assumption that, oh, you look good, everything's good. That's judging the book by the cover. We don't want to do that. We want to look inside and answer, where are you? Thank you all for coming.
That's Schwartzbard, thank you very much.
Thank you for having me. Sorry if I went too
No, you're great.